I'm going to talk to you about what we're doing in Wellington, New Zealand. So Wellington is the capital of New Zealand. We have a population of just over 500,000. It takes about an hour maximum to drive to the regional hospital by ambulance, hour and a half if you're using the helicopter. So what I'm going to do is run this presentation in 3 sections. First of all, there'll be a video of the technique that we're using to accelerate diagnosis of stroke in our patients when they're transported by ambulance. There'll then be an unscripted discussion between myself and the neurologist who went to Utstein that was mentioned previously. And then I'll finish off by talking briefly about a research study that we framed around the whole project.
Yeah, hi, I'm Anna Reinter. I'm a neurologist from Wellington Hospital.
Here. Hi, Doctor. This is Mary. Mary's 36 years old, and this morning had a sudden onset of left arm weakness. We were estimating about 2 hours ago. We've taken some vital signs. Mary's blood pressure is 180 on 100. She has a blood sugar of 6.0, and there's been no seizure activity noted.
And sorry, your name again? Was it Mary? Yeah. Hi, Mary. I'm Anna. I'm just going to ask you a few more questions and do a brief exam. Is that okay?
Sure.
All right. So this happened right around 8:40 this morning. Is that right?
Yeah.
And you were perfectly fine just before then?
Yeah.
Okay. Well, let's just check a few things. Can you tell me what month it is right now?
July.
Can you tell me how old you are?
36.
And can I get you to close your eyes?
And open them again? And stick out your tongue for me. Good, and you can put your tongue back. Now, can you repeat after me, we are inside an ambulance?
We are inside an ambulance.
All right, I'm going to show you an object.
Mary, what am I holding up in front of you here?
A pen.
Good. And what am I wiggling now?
Your thumb.
Can I get you to take your right hand and touch your left ear? Good, and you can put your arm back down. Now, can I get you to open your eyes wide so I can see your eyes really well? Good, and keep your head still and look all the way to the right and look all the way to the left. Now, Pete, can I get you to check visual fields for me? Great, thank you very much. Now, Mary, can I get you to show me your teeth like this? Good, and lift up your eyebrows high. Very good. Now, if I could get you to lift up your arms straight in front of you like this. I'm going to count till 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Great, thank you. Put your arms down. Now, Pete, if I could get you to tilt the camera a little bit so I can see the legs.
So here there's a coordination test, heel shin, and coordination test, finger nose. Test of sensation in the limbs, simple tests, nothing sophisticated.
All right, Mary, so thanks for that. The reason why we're doing all of this is because we think you may have had a stroke, and obviously that's a bit of a scary thing, but fortunately we have a medication we can offer you. The good thing about that medication is 1 in 3 people get a lot better, but there is a risk with it. About 1 in 40 to 50 people can have some bleeding because of it, and that can be quite profound, but obviously the benefit is a lot better than the risk, and I wouldn't be recommending it if I thought you'd be at particularly high risk. We'll go to the hospital now, and there we'll take you quickly to the CT scan. If the CT scan of your head checks out fine, we'll be able to give you that medication. And if we're ready to do that, would you be happy for us to give you that medication?
Yeah, sure, yeah.
All right, well, Pete, do you have any other questions for me at this point?
None at this stage, thanks.
And Mary, you all good at the moment? Okay. Well, I'll log off briefly and I'll go ahead and organize that CT scan, and then I'll see you when you get to the hospital. The Telestroke Initiative really started with stroke management inside emergency departments, where we've been doing it for some time, where we video conference neurologists to the bedside of the patient to do urgent assessments, to look at whether they have a stroke and whether they would qualify for an urgent intervention with IV thrombolysis. So what we thought we might trial is to see if we can move that assessment to happen earlier in the course of the patient's journey, namely while they're still in the ambulance. And the reason why we thought that would be a good idea is because stroke is very time critical, and every minute that we loses brain cells. So time is very much of the essence. We say time is brain. So we thought the faster we can assess the patient and the sooner we can do so, the better for the patient outcome. The other advantage of having the telestroke occur inside the ambulance is not only the time savings, but it also allows us to make a decision very early which might be the best hospital for the patient to go to. And so this is important because there's a new treatment called clot retrieval that can only be done in very few hospitals in New Zealand. So if we can very quickly decide what the best place for the patient is to go, then we can immediately transport the patient there, bypassing other hospitals, again, making the best treatment available to them much sooner.
Moving the assessment into the ambulance, into the pre-hospital environment. We're really getting ahead on both diagnosis and investigations and treatment and planning when the patient reaches hospital. And also, it's going to help with our deployment of the vehicle, whether the vehicle goes to the nearest emergency department or whether it goes to a centre that has full neurology support. It sounds really good, first of all, for the patient. Obviously, the time is critical for stroke. All our staff know that. But to be able to incorporate something into their practice that will help them actually accelerate, potentially, the patient's care, that is not only good news for the patient, I think it's rewarding for ambulance staff to be involved in that initiative. Certainly our staff are enthusiastic and they like to embrace new technology where it improves patient care.
So as part of this, we're doing a bit of a study actually to first launch this project, and we've been working between Wellington Hospital, University of Otago, and Wellington Free Ambulance to do a small cluster randomized controlled trial.
I think it's been of interest to us to discover how often people are misled by stroke mimics, for example. So I think having support with the diagnosis and being able to look at patients in conjunction with a neurologist, patients whose diagnosis is not necessarily clear, and to learn from the neurologist in improving the care of patients, I think that's really good. It's going to really, I hope, be the first of what could be more studies in the future relating or linking pre-hospital care to hospital care, and that holds a lot of promise.
So the study that was mentioned is intended really to assess diagnostic accuracy. Currently, paramedics diagnose 1,000 strokes in the patients that we transfer each year, so there's a significant caseload there. We want to look at how the telestroke will impact on onset to treatment times, and we want to compare it also with other established scoring systems. The choice of reperfusion technique also can be influenced this way. I had a phone call at 3:30 yesterday morning to tell me that they just actually done a clot extraction and it had worked very well, and this was following telestroke. We're very early in the study, but it holds a lot of promise, as I said. And we're looking at ambulance diversion. That's always a challenge from the deployment point of view. So how are we doing this? We've got a cluster randomization of two groups of ambulance. Group 1 is 5 ambulances that are set up for telestroke, and 5 that after the FAST test, which applies to all our potential stroke patients, are subjected to a PASTA test. This is nothing to do with the PASTA system that operates in the UK. It's a test that has been established at Auckland Hospital by the neurologist there, and it's based on the Los Angeles Motor Score, That score needs to be greater than 2. GCS motor score needs to be 5 or more. We don't apply this to children, and we try and exclude stroke mimics before actually labelling the patient PASTA positive or negative. Power calculations indicate that we need to have 55 patients in each of those groups to achieve the statistical significance that we require. This is a copy of the page of the new national guidelines, national ambulance guidelines in New Zealand, and it includes the PASTA test. You'll see that the Los Angeles Motor Scale is on the right side of the page. It's a motor score extending beyond facial weakness to include arm weakness and grip strength. Staff are expected to score on that. So we're interested to see how that score pans out, particularly as a predictor of large vessel obstruction, which is its intention. So we're including strokes within 6 hours. This was set up some time ago when we started to try and embrace clot retrieval. We're accepting wake-up strokes, and we're accepting patients whom the paramedics feel have clear signs of posterior, potentially posterior strokes as well. The ambulances and ambulance staff are provided with a 4-page instruction booklet. They've had teaching surrounding this, and they've had videos sent to them on the simple tests that you saw in the video there, tests of coordination, sensation, and visual fields. The process for them is quite simple. They do their fast test. If it's positive, they phone the emergency department to forewarn them, so pre-notification. They also give the patient's national health index number and their ambulance number. The ED in turn contacts switchboard, who send out an emergency page to the duty neurologist. The pager message has that information on it, and then the neurologist calls the virtual meeting room, which you saw there. That's provided by software from Vivid Solutions. The paramedics will already have called into that virtual meeting room and will be waiting ready. The summary that, or the abstract that I forwarded originally with Honoranta talked about results. Unfortunately, we don't have results to share at the moment. We're too early in the study. We encountered the sort of problems that you might expect, some technical problems, some problems that relate to circumstances that go outside the ambulance service, so the ED coordinators taking the right message, the switchboard sending the right message to the neurologist, and so on and so forth. But what I can tell you is that there's huge enthusiasm for this, which is why I've been woken at 3:30 yesterday morning, why I had a call at 5:30 last night, and why I was woken again at 5:30 this morning. So that just reflects the effort and the enthusiasm we're putting into this study, and I hope to have something to report in the not too distant future. Thank you very much.